So last week we talked about hypokalemia, and we are going to talk on the practical approach to hyperkalemia. You see on the left side, you see this is the table of contents or the floor plan for today's talk. So we start with the general issues related to hyperkalemia. Potassium changes are very common electrolyte disorders, next only to the sodium changes. Hyponatremia is the commonest, then hypokalemia and hyperkalemia, then comes hypernatremia, the order of frequency. These could be due to change in the intake of potassium or altered excretion through the kidney or transcellular shifts. Renal, hyperglycemic, medication causes are the causes of hyperglycemia, mainly renal disease, hyperglycemia, and drug-induced hyperkalemia are the common things. Okay. Now, diuretics and diarrhea we have seen are the common causes of hypokalemia. Several severe changes of hyperkalemia will lead to cardiac conduction abnormalities and neuromuscular conduction abnormalities, and can end up in cardiac asystole and death. It could be one of the very fatal electrolyte abnormalities. Okay, how do I pick up these people? From the lot of people who are coming to me in my IP or in the ICU, by history, physical exams, labs, and ECG. History is very essential, particularly drug history, physical examination, not very contributory, but still it is important. Labs, of course, are important, and ECG sometimes will be diagnostic. Hyperkalemia is treated with calcium, insulin with glucose, albuterol, and if necessary, potassium binders like K-acylate. These are some general observations. Now, if you want to understand hyperkalemia, you should know the ranges. Normal range is 3.5 to 5 milliequivalents per liter. We already know that it's an intracellular cation, 98% in the ICF, and only 2% of the potassium is in the ECF. In the ECF, it's around 4 milliequivalents. In the ICF, 150 milliequivalents. Okay, hyperkalemia is potassium greater than the upper normal limit, 5 milliequivalents per liter. A potentially serious medical condition, and the risk of severe cardiac electrophysiological abnormalities, including cardiac arrhythmias and sudden cardiac deaths. One of the causes of sudden cardiac deaths is, of course, hyperkalemia. Okay. The most important thing is the transcellular shift between the ECF and ICF. We have an idea about this, what affects the transfer of potassium across the cell membrane. We know if this is the cell and if this is the potassium inside 150 and outside are the potassium, which are in the ECF, there are only 4 milliequivalents. And what allows the potassium to go in is insulin. What pushes the potassium out is hyperglycemia. Likewise, the alpha receptors, alpha in, beta out. Alpha in, beta out. Acidosis in, alkalosis. Acidosis, it will be out, and alkalosis in. In acidosis, it will be potassium will move out, and in alkalosis, it will move in. These are certain other things which we have already seen, and now when we get to that, we'll again look at them. So it could be an increase. Most important, ICF, ECF. Second is the renal handling of the potassium. Third is either parenteral or oral load, and here you see you have insulin in, glucagon or glycose out. Go out. Into the cell, insulin. Outside the cell, from interior to the out of the cell, into the ECF, glucagon or hyperglycemia. Adrenergic alpha out, beta in. pH, acidosis out, alkalosis entry into. Potassium is poor man's pH meter. If you don't have a pH measurement in your small town, you can depend upon the potassium for the acidosis and alkalosis. Okay, if there is in acidosis, the potassium is lower, pH is low. Potassium is in the outside the cell, pH is lower, potassium is higher. Whereas in alkalosis, the pH is on the alkaline side, more than 9.4, pH is increased, and the potassium is lower. So, pH lower, potassium higher, that is the acidosis, pH higher, potassium lower, that is alkalosis. This is acid, this is alka. Remember that. And then T wave, as I told you earlier, is the 10th house of potassium. Potassium. More potassium, more is the 10th. Less potassium, less is the 10th. Okay? In hypokalemia, T inversion. In hyperkalemia, hyperacute T waves will be there. T wave is the 10th house of potassium. Right? Let's go further. Okay, now the most fundamental thing for understanding of potassium disorders and sodium disorders is the RAS equation, renin, angiotensin, aldosterone system, RAAS. Earlier it was called RAS, but in renin angiotensin system, now renin angiotensin aldosterone also is in the loop. That's why we call RAS and potassium. Let's see. The renal perfusion is one important thing. If there is a decrease in the renal perfusion, renin is activated from the juxtaglomerular apparatus. This renin is a potent enzyme which converts angiotensinogen to angiotensin, a decapeptide, 10 amino acids, and that is cleaved by the angiotensin converting enzyme in the lung, ACE, to an octapeptide. And this angiotensin 2 is a powerful vasopressor. Not only that, it acts on the adrenal medulla, on the steroid precursors, and synthesizes aldosterone, which is a mineralocorticoid. Means it retains sodium and it excretes potassium. It throws out potassium and retains sodium is the aldosterone. So, this is one basic understanding. Then as we go further, we know more about that. Now, RAS and potassium, further exploration. You know, the causes of hyper or hypokalemia can be threefold. One is the intracellular, extracellular, transmembrane movement of the electrolyte. Transmembrane movement of potassium. Potassium coming out or potassium going in. Here, what goes inside? What puts inside? Insulins, catecholamines, and alkalosis. They push inside. The opposite, glucagon, and then all beta blockers, catecholamine blockers, and then acidosis bring the potassium out. This is what we have already seen. Now, we already know the renal handling of the electrolytes. If there is aldosterone, sodium is conserved, potassium is excreted. If there is no aldosterone, sodium is washed out and potassium is conserved. That is hyperkalemia. So, excess of aldosterone, hypernatremia, absence or deficiency of aldosterone or angiotensin, hyperkalemia. So, this is the renal handling. The opposing hormones here for angiotensin and aldosterone are the atrial natriuretic peptide and B-natriuretic peptide. They just oppose the action of aldosterone and cortisol and of course angiotensin. Now, peroral intake of potassium containing foods, if it is increasing, it can lead to hyperkalemia. Gut plays a very important role in excretion, but we don't lose, we don't have, this is very important in hypokalemia. In diarrhea, we lose a lot of potassium. But for hyperkalemia, gut playing a role or not excreting potassium is not very important. Increased intake either by oral or by vein, but treating hypokalemia into the system, you can infuse into the system. So these the causes are number one, transmembrane shifts here. Number two, renal handling. Number three, increased oral or parenteral input of potassium into the system. Okay, now I am going to give you, this is a very exciting slide which tells you the pathogenesis and the etiology in one go. Okay, let us see that. We have here the juxtaglomerular cells. This is the glomerulus. The juxtaglomerular cells those are the juxtaglomerular cells. When the afferent arteriole constricted or there is a lesser blood flow in the afferent arteriole, body senses that there is a need for fluid and electrolytes, and it stimulates the production of a substance called renin. There are several diseases which can interfere with the juxtaglomerular cells. What are they? And that is renin release. They prevent the renin release. NSAIDs, beta blockers, cyclosporin, tacrolimus, diabetes, elderly, they impair the renin. Number two, once the renin we know is a very potent enzyme to act on angiotensin 1 and then that conversion of angiotensinogen to angiotensin. Actually, renin is the enzyme angiotensinogen. Angiotensinogen is the substrate which is acted upon to form angiotensin 1, and we have drugs which are called direct renin inhibitors, Aldosterone. Aldosterone is a direct renin inhibitor. That is step number 2. And now we have a powerful enzyme in the lung which converts angiotensin 1 to angiotensin 2. And if at all there is a very powerful vasoactive molecule on the whole globe, it is angiotensin 2. Remember, angiotensin 2 is the most powerful vasoactive molecule. And that is under the influence of angiotensin converting enzyme. And if you angiotensin converting enzyme converts angiotensin 1 freely to angiotensin 2, if you have a blocker, you use them to treat hypertension. Direct inhibitors and AC inhibitors are used to treat hypertension. Then this angiotensin 2 can be blocked by drugs called angiotensin receptor blockers, or so-called your, please mute your mics. All of you, please mute your mics. All of you, please mute your mics. So angiotensin receptor blockers or ARBs, you know, losartan, telmisartan, valsartan, irbesartan, candesartan, all these sartans are angiotensin receptor blockers. AC enzymes are all the prils, ramipril, isinopril, lisinopril, and then, you know, the captopril, all those prils are the NLFpril. These are all the angiotensin converting enzyme inhibitors, ARB blockers. So what does they do? They will not allow the angiotensin to sit on the adrenal gland. So much so, the adrenal gland has to produce aldosterone, and that is not affected. So there will be angiotensin converting enzyme inhibitors, ARBs. They also have the same effect. Now, the aldosterone metabolism itself can be impaired by conditions like adrenal disease, heparin use, ketoconazole, and antifungal agent. That is the 5th etiological factor. And 6th, the angiotensin receptor blocker can be, aldosterone receptor blocker can be used. We know the eplerenone and then the spironolactone, drospirenone. These are the drugs which are these are called the EMR receptor blockers or angiotensin receptor blockers, mineralocorticoid receptor blockers. And that is the mechanism number 6. Okay, now up to that, if everything is fine, there could be another blocker for the excretion of sodium. And these are amiloride, trimethoprim, trimethoprim, pentamidine, acts on sodium resorption in the distal tubule. So much so sodium is not resorbed, and potassium. And when you use those drugs, the sodium resorption is interfering, and then the potassium is they are potassium sparing. So what they do is normally the absence of these drugs, sodium is absorbed and potassium is excreted. But when these drugs are there, sodium reabsorption here is blocked. So no sodium is coming into the cell. Potassium is retained intracellularly. This overflows into the paratubular capillaries, and then hyperkalemia occurs. So how hyperkalemia can occur? Number 1, Of course, this is the seventh mechanism. So when you are using, when you are having diseases like this which interfere with the renin, when you are using direct renin inhibitors, or when you are using angiotensin inhibitors, or when ACIs, the prils and the sartans, when you are using losartan group of drugs, the blockers, or when there are mechanisms which are interfering with the aldosterone metabolism itself. Number 5, and ultimately the mineralocorticoid receptor blockers like eplerenone, dosiprenone, spironolactone is commonly used is your spironolactone, and diuretics like amiloride, triamterene. These interfere with sodium resorption into the cell, so much so sodium is in the urine. Potassium cannot get exchanged unless sodium comes inside, and there will be hyperkalemia. I tell you, if you know this, you have not only known the etiology, you know the pathogenesis, you know the treatment too. This is one diagram in one go, etiopathogenetic management of hyperkalemia. So then what is the etiology? Obviously, this is the etiology. So pseudo hyperkalemia, a condition called pseudo hyperkalemia, which is not true. Suppose there is excessive hemolysis. In a case of hemolytic anemia, potassium is intracellular within the RBC. All that is spilled out into the circulation, and suddenly you see hyperkalemia. Once the hemolytic episode stops, the hyperkalemia resolves. It is not true hyperkalemia, it is pseudo hyperkalemia. Likewise, thrombocytosis, more number of thrombocytes are there. These thrombocytes exude the potassium into the circulation. Or if there is severe leukocytosis, and ultimately these leukocytes will be destroyed and potassium comes out. Or if you ask the patient to take venipuncture, to clench the fist very tightly to do a venipuncture, that little bit of pressure can increase the potassium. So if you are looking for potassium, don't ask the patient to clench the fist. Just like that, you take the blood sample. Okay. Release from the cells. What cells it can release when there is exercise or when there is reason for rhabdomyolysis. The skeletal muscle cells are broken down, the potassium spills into the circulation. Or if there are tumors in the body, these tumors go on lysing. These tumor-lytic syndromes are quite common, particularly in the advanced stage of cancer. That can increase the hyperkalemia. These are pseudo hyperkalemia released from cells are not very important causes of hyperkalemia. What is most important? Abnormal redistribution, that is ECF-ICF transfer, insulin deficiency, because without insulin, potassium cannot go inside. It remains in the circulation. Hyperkalemia. We know that corticosteroid hormones put this one into the cell. When you block those hormones, potassium remains outside the cell. People who use beta blockers or metabolic acidosis, usually acidosis, we told you when there is acidosis, pH will be low, potassium will be high, because in acidosis, potassium out, in alkalosis, potassium in. The other one is familial hyperkalemic periodic paralysis. Familial hypokalemic periodic paralysis is also there. This can occur both when the potassium goes downward or upward, and the causes and the basis are different, which is not the subject of today's discussion. If we are discussing hyperkalemic periodic paralysis, then we will go into those things later on. So remember, this is the most pronounced and important problem, the potassium distribution across the cell membrane. And this is powered by NAK ATPase. That is the pump. This is not an enzyme, this is a pump. The cell is like that, there is a pump there. That pump is the NAK ATPase. And this is opens and closes, enters, allows sodium inside and potassium outside. And we have seen what are the conditions which push the potassium out or in, and vice versa. Okay. Now, decreased renal excretion is the second most important cause of hyperkalemia. What is that? Acute kidney injury or CKD, chronic kidney disease, or renal effect of SLE. This is called lupus nephritis. lupus nephritis. Aldosterone, we know, conserves sodium, excretes potassium. Aldosterone deficiency cannot conserve sodium. Sodium is lost, potassium is retained, hyperkalemia. Adrenal insufficiency, also the same thing. Adrenal insufficiency also, sodium is lost and potassium increases. And we have read these things under hyponatremia. Now they also in turn cause hyperkalemia. In heart failure also there is a sort of excess load of the solute presented, and the sodium is retained, and that sodium is presented to the distal tubule. In exchange, more potassium is brought into the system. Potassium sparing drugs, spironolactone, and triamterene, amiloride, eplerenone, dasyprenone, all are the potassium sparing drugs. So this is an etiological table where you can see the different etiologies based on membrane redistribution problems, excretion problems, release from the cells, pseudo hyperkalemia, in that order. This we do not require to treat at all because this is dependent on the underlying cause. If the underlying cause disappears, potassium will of course come to normal. Of course, we have to treat the other causes. Now, a detailed chart can be made out of it. Excretion impaired, acute kidney injury, chronic kidney disease, ACE inhibitors, ARBs, non-steroidal anti-inflammatories, potassium-sparing diuretics, trimethoprim, heparin, lithium, calcineurin inhibitor. This is how the books give, but there's no use by this way. You have to keep the idea in what according to the diagram. According to this diagram, if you keep, you know how, where, what is happening and where. Transcellular shift, insulin, acidosis, hyperglycemia, mannitol, beta blockers, digoxin, one important thing. Somatostatin, succinylcholine, cell breakdown, I told you, in tumor lytic syndromes, hyperkalemic periodic paralysis. Same thing, reordered there and it is listed here. So decreased distal renal blood flow, hypoaldosteronism, primary renal tubular defects or other causes, increased intake when it can occur, potassium supplementation, red blood cell transfusion, foods high in potassium, we come to the table, potassium containing salt substitutes, protein calorie supplements, which of course add potassium, and penicillin G in large doses. It is a potassium penicillin. Phenoxymethyl penicillin is penicillin V. Like that, potassium penicillin is penicillin G. If it is used in large doses to treat, 10,000 international units 3 times or 4 times a day for about a week or so, as in case of leptospirosis you use. And some form of pica also are associated with increased potassium. But this is, as I told you, is not a very important cause of hyperkalemia. Okay, but hypokalemia, it could be a problem because less intake could be a problem, but over intake of potassium generally is not very important. Pseudo hyperkalemia, we have seen hemolysis, that is clenching of the fist, tourniquet, blood sample. After that, you cool the blood sample and measure potassium, it will be higher. Intravenous fluids with potassium, if you have administered, that can lead to pseudo hyperkalemia, cell hyperplasia, erythrocytosis, thrombocytosis, familial pseudo hyperkalemia. Leukocytes of more than 75,000 K can cause sort of cell lysis that can lead to hyperkalemia, which is pseudo hyperkalemia. Now, I was telling you, this will be a short notes for you in your PG examinations. Discuss the role of drugs and potassium. Commonly asked question. You may be ready with this table. If you have this table, it's very easy to blast. Even in the Viva also they may ask. Can you tell me something about how drugs interfere with potassium? You see, drug-induced transmembrane involvement, drug-induced aldosterone problems, drugs that cause tubular resistance, and potassium-containing agents. Divide them into 4 parts. Non-selective beta blockers, digitalis, and then intravenous cationic amino acids, mannitol, succinylcholine compounds. What are these? Isosuccimide, fensuccimide, not very much used nowadays. These were used earlier as anti-epileptics. Some cases, we do use in petimol epilepsy, some ethosuximide. So that they can cause. And drugs that affect the aldosterone axis, The ACE inhibitors, ARBs, renin inhibitors, COX-2 inhibitors, NSAIDs, calcineurin inhibitors. We have already seen that chart there. Okay, now those which increase the tubular resistance to the action of aldosterone secretion is all right, but the tubules are not allowed to function normally. There is aldosterone resistance because of mineralocorticoid receptor antagonists like spironolactone, eplerenone, or the dosipredone. These are the drugs. Or potassium sparing diuretics like triamterene and then amiloride or trimethoprim and pentamidine also are known to interfere with sodium reabsorption in the DCT. Sodium is not reabsorbed, so there is no chance of potassium escaping into the urine, and then potassium goes up in the blood. Finally, salt substitutes, it's called LONA, low sodium aldehyde. This contains potassium in place of sodium, and penicillin G and stored blood products can be the reason for potassium containing agents. This table summarizes drugs and potassium. Then another, as you have seen, ROS and potassium, CKD and potassium is also a very important area to understand. So hyperkalemia and CKD, patients with CKD are at a higher risk of hyperkalemia. Always remember, if the creatinine is more than 2.5 in women and more than 3 in men, you are in for a problem of hyperkalemia. So this is what is called creatinine more than 2.5 in women and more than 3 in men could be a trigger for hyperkalemia due to their decreased ability to excrete. What happens? There is a tubular function is abnormal. So the tubules they have decreased ability to excrete the potassium, particularly to secrete the potassium. Potassium is excreted by active secretion, and that secretion is against the sodium, and that is at fault. And this CKD could be a harbinger of other comorbid conditions like diabetes mellitus and cardiovascular disease. So if you have a patient with CKD, you have a patient with diabetes and CKD, or CVD and CKD, you are in for trouble, and keep looking for hyperkalemia and avoid agents which will increase the potassium. That is why when you are using ACE inhibitors or ARBs, you always check the serum creatinine. If the serum creatinine is in these areas, you are not supposed to use these drugs. You have to stop the drugs. And once the serum creatinine comes down, you can use the drugs. This is as a physician. If you ask the nephrologist, he will still use these drugs in spite of serum creatinine being more than 2.5 or 3 because they know the beneficial effects sometimes outweigh the damage. But beware, when you use ACE inhibitors or ARBs in the presence of CKD with raising creatinine, always monitor potassium. Hyperkalemia has been reported in around 50% of the cases of CKD compared to 2% of general population. Just you can see how most common in CKD compared to general population. If you do hyperkalemia screening, only 2% of general population will have. In CKDs, every alternate patient will be having hyperkalemia. So what did we learn? The ROS system there and the systems that push the potassium out, like lack of insulin, hyperglycemia, and then the acidosis or the beta blockers, they keep the potassium away, not entering into the cell and keeping outside. That is the major mechanism. The second mechanism is the aldosterone axis, where the ACE inhibitors, ARBs, renin blockers, aldosterone blockers, they all work. That is the major important. Second one is the CKD. So every patient of hyperkalemia, look for ROS axis and look for factors which are keeping the potassium outside the cell and not allowing it to cross the cell membrane through the sodium potassium ATPase pump. And that is important, and having done that, you have to assess the kidney, because we know kidney could be the culprit in handling the, not sending the potassium into the urine and hypercalcemia. Okay, I'm going to summarize in this slide again, a very summary slide on CKD and potassium. If you have this slide, everything about CKD and potassium, you can infer. So the central thing is hyperkalemia. How that is occurring? On one side, acute kidney injury, on the other side, chronic kidney injury. Okay, acute kidney injury, there is decreased blood urine flow, there is inability of the kidney to excrete potassium because urine flow itself is reduced. Or an acute kidney injury, there is tissue injury. Tissue injury, we know, leads to spill of potassium into the system, high load that can cause. Or there is a decrease in the GFR, there is filtration itself is less, so potassium also is retained. Or there is a tubular interstitial damage that could again inability of the tubules to secrete potassium, excrete potassium, because mainly it is by secretion that is excreted, and that is again higher load. So all these will pave way to hyperkalemia. Okay. In acute kidney injury, there could be the associated diabetes is there, and these people will have relative insulin deficiency. There will be hypertonicity, a diabetic fellow suddenly becoming acute kidney failure. He has higher relative insulin deficiency, hypertonicity. These keep the potassium outside. They will not allow the potassium to enter inside because insulin is required to go inside, and this fellow is having less insulin. Or the hypertonicity itself keeps the high glucose, keeps the potassium outside. That is why in diabetic ketoacidosis, what you do? There will be hyperglycemia, hyperkalemia. You give insulin, glucose moves inside, and potassium also goes inside. And treatment is done. Okay, inability to induce tubular potassium secretion is another problem due to hyperreninemic hypoaldosteronism. Okay, hyperreninemic hypoaldosteronism. All these from here to here, all these from here to here can occur in diabetics, and that can lead to hypercalcemia. Okay, I have got that. This side I come, chronic kidney disease, metabolic alkalosis. I know in alkalosis potassium will be outside. There is kidney transplantation has been done. Then it results in renal tubular acidosis, and you use calcineurin inhibitors there that can cause potassium shift. Dietary modifications are done in chronic disease, kidney disease, and that can lead to increased dietary potassium intake. That is one area. Or you may be using beta-2 agonists. We know beta-2 agonists keep the potassium outside the cell, decrease the renin production, decrease the ability to distribute the potassium. And NAK ATP is inhibited, potassium is retained outside, and that can lead to hyperkalemia. How about cardiac glycosides? Cardiac glycosides act by this mechanism. How about mineralocorticoid receptor blockers? They block the aldosterone there. How about heparin? Heparin blocks the production of aldosterone, decrease potassium secretion. And ROS inhibitors. All these are the ROS handling. This is the beta blocker, and these are the chronic kidney diseases, metabolic acidosis. This is acute kidney injury, and this is your diabetes. All of them are leading into hyperkalemia. A very summary slide for all the mechanisms that are happening. Okay, sometimes a patient is anemic, you transfuse blood, and this blood is a stored blood, and this is under refrigeration that contains high potassium in the plasma of the transfused thing. That is why usually whenever you transfuse, you try to bring the packet onto the room temperature and then only transfuse. Frequent transfusions can also lead to hyperkalemia. Beware of those things. Okay. Again, summarizing the whatever we have learned in a one simple table. If there is aldosterone decrease, it increases the sodium reabsorption and increases the potassium excretion. Increases the resorption of the sodium and increases the potassium excretion. This is the mechanism of aldosterone habitat. But then in the absence of that, if the aldosterone is there, potassium will go down. If the aldosterone is not there, aldosterone deficiency, potassium will go up. Insulin puts the cell, potassium into the cell. And in the absence of insulin, potassium increases. When there is insulin excess, potassium decreases. If insulin is low, potassium increases. This also we know. Beta adrenergic blockers, beta adrenergic agent stimulants, they put the increase the skeletal muscle uptake of potassium. Beta adrenergic blockers increase the potassium. Alpha adrenergic agents Alpha adrenergic agents, they increase the potassium, hyperkalemia, and impair cellular potassium uptake. Acidosis, we know, increases the potassium because it keeps the potassium outside the cell because the NAKTP a pump is affected. Alkalosis, just the reverse. Cell damage, lysis produces potassium, spillover of potassium into the cell and through the cell membrane. So again, always remember there are factors which keep the potassium into the cell, like this one, and this one, which will push in, and the opposite of that lack of insulin, beta adrenergic blockers, alkaloacidosis, they keep the potassium out. And of course, aldosterone presence, low potassium and high sodium. In the blood, aldosterone absence, just the reverse, sodium is washed out, potassium is produced, and potassium is retained. Okay. So, yeah, does every patient of CKD develop this particular condition? No, there are certain risk factors. You can presume if there is increase in potassium intake, there is already associated metabolic acidosis. You are using some ROS inhibition by ACE inhibitor or ARB or CAD and PAD. So this will give you an idea. The moment you see the patient, is he in heart failure? Is he in CAD? Is he a PAD, peripheral arterial disease? Is he a diabetic? Is he using ACE inhibitor ARBs? Is there acidosis? Is he taking potassium supplementations? This will tell me, yeah, this is a CKD patient. I have to correct this thing. Otherwise, I run the risk of sudden cardiac death and cardiac arrhythmias related to hyperkalemia. Okay. What are the symptoms? Unfortunately, not many symptoms. May not report non-specific symptoms. Palpitation may be there, nausea, muscle pain, weakness, dyspnea. These are a very general, vague symptoms. Hyperkalemia can lead to disturbance of cardiac rhythm, which can be fatal, and that time he will be symptomatic. Not a very symptomatic disease. Okay. Hyperkalemia and serum potassium levels. Just like hypokalemia, are there any grades? 3 to 5 is the normal range, more than 5 mild, more than 5.5 moderate, more than 6 milliequivalents per liter severe. Severe hypokalemia is anything more than 6 milliequivalents per liter. It is life-threatening. Unlike hypokalemia, hyperkalemia can be life-threatening. Particularly if it is acute, you have to bring the potassium very quickly down. Otherwise, cardiac arrhythmias can occur. Okay, acute versus chronic. Acute requires immediate treatment, cardiac monitoring is required, acute medical treatment of giving insulin to cell, send the potassium into the cell, and the albuterol, and then you have to use probably dialysis also to remove the excess potassium. Chronic requires ongoing treatment of the underlying condition, underlying disturbance, you correct it, use non-pharmacological methods and pharmacological methods. This management is very sort of rapid in acute, and you can take a little while in chronic, but you have to mind about the underlying disorders. All of these slides have an annotation, as you can see at the bottom, and every slide is from different references, as you can see here. And you please note that these are made out of excellent reference materials, which have been very good resources for me to prepare this particular presentation. So needless to say, a lot of effort is required to put up a presentation of this nature in a summary way so that you people can use it. Okay. Now, how do I diagnose? Clinical history, physical examination, review of the medications. I tell you, this is the one which made me pick up several cases of hyperkalemia. Looking at the medication, I can easily suspect what are the medications. We have already got the list. ACEs, ARBs, direct renin, and diuretics like potassium-sparing diuretic, trimethoprim, pentamidine, triamterene, and then amiloride, and then eplerenone, dosiprenone, or spironolactone. Any one of these drugs And assessment of the cardiac function. I know a patient has got CVD or heart failure is at a greater risk. Likewise, look at the CKD, very important. And hydration status, very important. ECG could be a very good guide, and comprehensive lab workup is also required. Now, what are the ECG changes when they occur? If the potassium is between 5.5 and 6.5, there is hyperacute T waves. That is called tall peak T wave. T wave is the 10th house of potassium. And potassium is poor man's barometer. If potassium is more, patient is probably acidotic. pH is lower. If the pH is higher, alkalotic, potassium T waves will be down and potassium will be lower. So that way both the pH and the T waves and the potassium are interrelated. 6.5 to 7.5 milliequivalents per liter, a higher, next higher grade of potassium, loss of P waves. This is the P wave here, and that is missing, loss of P wave. If you see in a patient who is having CKD, who is having using ROS inhibitors, and his P wave is missing, and there is a hyperacute T wave associated, you are immediately looking at the ECG. You can say this fellow is having severe hypokalemia. I tell you at least 3 or 4 patients I have picked up looking at these two changes, that this patient is hyperpotassiemic. Did the potassium within 1 hour we got the report and we treated and they were all right. If you miss this, we will miss the patient forever. Okay. 7.8 to 8 milliequivalents of widening of the Qrs complex occurs. Qrs normal is 0.12 seconds, upper limit anything more than 0.12 seconds is widened Qrs complex. 8 to 10 milliequivalents, you get a sine wave. This is the sine wave pattern. As though now the P wave, QRS, everything, T wave look like, yes, like that. This is the sine wave pattern like thing you will see. And ventricular arrhythmias can occur, asystole. And also remember, ECG changes may not always be present. No, you can't say, no, ECG is normal, so it is not hyperkalemia. I cannot say that. If ECG changes are there, they are diagnostic. That means they are specific, but their not absence is not sensitive enough to exclude the disease, exclude hyperpotassium. Presence of these changes is specific enough to rule in hyperkalemia. Absence is not sensitive enough to rule out hyperkalemia. Sensitive test rules out the disease. Specific test confirms the disease. Okay? This is a real-time ECG of one of our patients. You can see that hyperacute T waves, very tall T waves. Okay? Of course, this patient still P waves are seen. That means his level of potassium is not more than 7.5. Then at that case, we will lose the P waves also. And finally, sine waves will appear. This is the stage you should pick up. This hyperacute T waves, if you see, there are two or three important differential diagnoses. What are those? Number one, impending myocardial infarction. Impending myocardial infarction, patient presents with hyperacute T waves in the first 15-20 minutes, then that will be replaced by ST elevation, T inversion, Q waves and all that. Second, hyperkalemia. Second one. Third one is severe LVH, acute severe LVH, particularly volume overload. These are some of the conditions which produce hyperacute T waves. Okay. I also gave you the DD of hyperacute T waves. Now, how do I manage these patients? Where is the time now? Okay. Some time is still left. Acute management, chronic management. Needless to say that we are getting different sort of annotations there. Prevent potentially life-threatening cardiac conduction and neuromuscular disturbance. And this is the first step. We have to save the patient from cardiac conduction abnormalities. Number two, try push the potassium into the cell. How? By giving insulin, by giving albuterol, by giving calcium, very important. IV calcium. The moment the calcium goes into the system, potassium is shunted into the cell. Eliminate excess potassium by by various mechanisms, including dialysis, and of course, resolve the underlying condition. Okay. In chronic, prevent the development and recurrence. Here, the disease is you treat the fellow and see that he doesn't recur. That is number one. Treat the underlying defects of potassium, mostly transmembrane or mostly CKD or mostly it is RAS problems. So chronic condition, three things: one transmembrane, two CKD, and three RAS system problems. So tackle them and then increase the potassium excretion. Use diuretics or you can use K-oxalate potassium binder in chronic case. Never try a binder in acute case. Binder takes at least 2 to 3 days to work and it is not for acute case. Never try that. Here we have to see that somehow the potassium is pushed into the just like some dangerous thing is coming. What you will do? Send all the people inside and ask them to lock inside so that the people are safe inside. So potassium, once it is inside the cell, the body is safe. Okay, and later on you can slowly correct the abnormality. Okay. Now these are the three management approaches: antagonize the transmembrane shift, driving the ECF potassium into the ICF, remove the excess potassium from the body in that order of importance. Antagonize the transmembrane shift. The transmembrane shift is causing the potassium to stay outside the cell in the ECF. You see and alter the environment in such a way that the potassium again goes back. For example, correcting the acid-base balance. In acidosis, potassium is not allowed to enter into the cell. It is outside. In alkalosis, potassium can go into the cell. Second one is driving the ECF potassium into the ICF potassium. Here comes the treatment with glucose and insulin. If you infuse glucose and insulin, insulin will allow the glucose to go in and that along with the glucose, potassium also goes inside. Okay. Now, remove the excess potassium by using diuretics, by using binders, by restricting intake and all that. So let us see each one. Acute management, the watchwords are stabilize, shift, and RRT. These are the watchwords for acute. Stabilize the patient from life-threatening toxicity and EKG abnormalities. How do I do that? Initiate monitoring, give immediate calcium gluconate. This calcium gluconate within a few minutes tides over the acute catastrophe of cardiac emergency. Then you start giving glucose with insulin to shift the potassium from the ECF to the ICF, dextrose and insulin. Dextrose infusion or insulin, either insulin alone or if the patient is already hyperglycemic, you don't have to give dextrose, just insulin alone is sufficient. If the patient is normoglycemic, you give dextrose and insulin. And also give beta adrenergic agonists, albuterol, because beta blockers we know keep the potassium out. Beta adrenergic agonists, these are not antagonists. Antagonists keep it out, agonists push it in. So these are the two important things. Beta adrenergic agonists by needle can be given. Renal replacement therapy RRT, either peritoneal dialysis or hemodialysis or continuous renal replacement therapy. And here comes the role of bicarbonate. If you infuse bicarbonate, the relative acidity in the environment is neutralized. Once the acidity is neutralized, the potassium moves into the cell. Bicarbonate might come handy. And at the end, you can start potassium binders, which will prevent the absorption of potassium, like K-oxalate, a binder. In chronic, remove or manage the ongoing causes of potassium. Diet and potassium-free foods you have to give, because diet and all you cannot tie in acute. I want to restrict potassium intake and correct acute. Not possible, because by the time you restrict for 2 days, the fellow will be gone. You have to be very crisp there. In chronic, you have to do. Diet is very important. And here, review of the medications, stop those which are producing hyperkalemia like ACE inhibitors, ARBs, spironolactones, eplerenone, or the dosiprenone, or triamterene, or amiloride, or renin inhibitors, alescarin, all those drugs. Manage diabetes, hypertension, CVD, comorbidities. Increase the excretion. How do I do that? I have to use not potassium sparing spironolactone. The most preferred diuretic is furosemide to lose the potassium. In fact, one of the side effects of furosemide use is hypokalemia. It pushes the potassium out. So that is very handy in hyperkalemia. You use that side effect for a good effect here. So the loop diuretic furosemide is the drug of choice for diuretic. Potassium binder, K-xylate. Okay, dietary management, avoid the following: potassium intake and potassium salt substitutes. Lona is a potassium salt substitute that you avoid. Some herbal preparations, I don't know what is noni, alfalfa, dandelion. These have to be, they have to be avoided because they increase the potassium. Potassium rich, heart healthy diets. Lot of ads will be coming. This is a very good drug. It protects the heart. You take this, contains potassium rich, heart healthy diet. Okay, good in a normal person, but not in a fellow who is hyperkalemic. Because suppose fruits, for example, banana, very good rich in potassium. Tomato, very citrus fruits, rich in potassium. All the beans, legumes are rich in potassium. Nuts, they are rich in potassium. They are all heart healthy, but very unhealthy for a fellow who is having hyperkalemia. So you have to avoid those things. Now, here is a table which tells you the relative content of high potassium foods. The pinto beans, the red beans, the raisins, you say kismis pallu antam kada. These raisins, they contain 1 cup of them around this many milligrams of potassium. This many milliequivalents. Honeydew, half a melon will contain 24. Nuts will contain 18. Black-eyed peas 16. Collard green 13. In nutshell, all the beans and nuts, they contain more potassium. Banana, medium-sized 11. Tomato 9. Orange and citrus fruits 9. And 1 cup of milk 150 ml is 9 milliequivalents of potassium. Why do I know this? Because in my patient of hyperpotassium, hyperkalemia, I need to avoid the black beans, the raisins, the nuts, the bananas, the tomatoes, the orange. What is not written here in Western countries, they don't use tender coconut very much. We have tender coconut. This tender coconut water is very rich in potassium and must be avoided. So you should not use tender coconut. Okay, no problem. When the coconut water taagandi, tender coconut, no, gone. Patient will go into cardiac arrhythmia and die. So it must be forbidden. Tender coconut water. Okay, these are some of the high potassium foods. Now, restriction of dietary potassium. How much I should give actually? How much potassium should be the intake? Approximately 4.5 grams of potassium is required per day. The guidelines are if the patient is CKD stage 3 or 4 with the GFR around 15 to 60, you have to give 2.5 2 to 4 grams per day is the intake of potassium. DASH diet alone in systolic hypertension. DASH is, there is a study called DASH study where they use diet alone to treat systolic hypertension. And they used a particular diet, and that is called the DASH diet, and that contains 4 to 4.5 grams. If the patient is CKD, his intake should be half of that. Hyperkalemia risk patients with GFR less than 30, or if they are on ACR, ARB therapy, are conditions that increase the potassium. More stringent potassium intake, you have to very stringy, don't allow them. And also low potassium target of 2 to 3 grams. And you may consider either reducing these drugs or stopping these drugs. In patients, what dietary potassium requirements are this much. Now, RAS inhibition and CKD, AC inhibitors are well established treatments. These are very used in hypertension, in CKD, in CHF, and many other chronic conditions, diabetic nephropathy. Very commonly prescribed enalapril, captopril, ramipril, lisinopril, or losartan, candesartan, irbesartan, valsartan, telmisartan. Left and right they are being prescribed. Now, however, in ROS inhibition can impair renal potassium. Thus, it increases the risk of hyperkalemia. Then what to do? Is there a dilemma? Should I stop the drugs or should I continue? No, you continue them at an optimal dose and try one step below that and monitor the potassium. Particularly the patient is CKD, you have to be there. So you cannot afford not to monitor potassium when you are using these drugs. So managing ROS inhibition, CKD and hyperkalemia. Three things are there. ROS, CKD, hyperkalemia. In such a case, monitor EGFR and SCR and the serum creatinine, discontinue the drugs that increase hyperkalemia, prescribe low potassium, prescribe loop diuretics, correct acidosis, initiate low dose ACI and monitor for potassium. And then newer potassium binders can be used. So another 5-10 minutes. So I'm going by a flow chart. The potassium is more than 5 milliequivalents. Are there warning signs? That means it's acute emergency. Yes. Then urgent therapy, no question of evaluating whether it is RAS, this, that, transmembrane, all those things are later. First, we have to save the heart. What do? Give calcium gluconate and then insulin with or without glucose. So that will go to the figure 3. Now, there is no emergency. Is it pseudo hyperkalemia? Is there hemolysis? Is there thrombocytosis? Is there leukocytosis? Is there cell turnover is more? No further action is required. No, it is not pseudo hypokalemia. Pseudo hyperkalemia, potassium is more than 5. There are no warning signs. Yes, I can now work up whether it is transcellular shift. Transcellular shift means we treat it. What are the transcellular shift? Insulin, and then beta agonist, and then acidosis. These are some of the conditions which can produce transcellular shift and then work on them. No, there are no transcellular shift causes. And we are here. Then how much is the sodium going in the urine? Is the kidney able to excrete sodium? More than 25 milliequivalent? That is the question. Yes, it is able to. No, it is not able to excrete. Oh, kidney is not excreting sodium. Okay, that is the reason there is decreased renal blood flow, kidney injury is there, chronic kidney disease, congestive heart failure, cirrhosis of liver. So that is, we are in for a CKD there. Now, if the kidney is able to excrete more sodium, that means aldosterone is low, that is why sodium is not conserved and it is leaking in the kidney. More sodium is going out, that means I am in with an aldosterone problem. Then how do I know? Is it primary or secondary? Look at renin. Is the serum renin low serum renin? Yes, it is serum renin is low. Hyperglycemia, primary renal tubular defect, medications like anti-inflammatory drugs, non-steroidals or beta blockers. No, renin is not decreased, then primary adrenal insufficiency, wherein you have both renin as well as aldosterone increased, medication use, angiotensin converting enzyme. No, the serum aldosterone itself is not low, then you are in for the pseudo hyperaldosteronism and SLE, nephritis, sickle cell disease, primary renal. This is a diagnostic algorithm as well as a treatment algorithm. So again, I am going more than 5 milliequivalents potassium. First question is, are there emergency signs? Yes, treat it, no investigation, no evaluation. If there are no emergency signs, what do? Is it pseudo hyperkalemia? Do an LDH, simple LDH, haptoglobin, excludes hemolysis, gone. Then it is not pseudo hyperkalemia, it is true hyperkalemia. Here, are there transcellular shift? Are there reasons like, lack of insulin or beta blockers or acidosis, which are the transcellular shift? They are there, then treat them. If they are not there, how about the kidney? Is it able to manage with the sodium? No, kidney is not able to manage even sodium. Oh, we are in for a renal disease, it's chronic kidney disease. Retaining, salt retaining conditions like congestive heart failure and cirrhosis. No, kidney is able to excrete sodium well. Oh, that means the aldosterone is low. That's why sodium is going, potassium is increasing. Okay, let me check the aldosterone. Is it a yes? Look at the renin, if it is yes or no, depending on the causes. Suppose the aldosterone is normal, then you are in for hypoaldosteronism, and then the amyloidosis, SLE, and other things. Now the treatment algorithm here, that is the diagnostic algorithm. More than 5, emergency, go to figure 2, we consider dietary modification, consider medication adjustments, consider binder. So that is the evaluate the potential cause. Then if it is more than 5, is it less than 6? Then if it is less than 6, between 5.9 and you go this way. No, it is not less than 6, but more than 6. Okay. Then are there any risk factors present associated with hyperpotassemia, or hyperpotassemia itself is more than 6? Then look at the ECG. Is the ECG normal, or ECG is having already changes there? Then the ECG is abnormal, then you are in for trouble, and IV calcium is the treatment. Okay, in addition to A, give intravenous calcium gluconate plus A. What is A? A is insulin plus glucose, with or without glucose, depending on whether he is a diabetic or not. Nebulized albuterol, which is a beta agonist, and then consider dialysis, and also serial ECG monitoring. Monitor potassium and glucose. Potassium has come down from more than 6 to less than 6. We are very happy. Continue to monitor. If it is not, again go back to this. Okay. Now, what are the modifications you consider? Consider dietary modification, adjustments, and sodium polystyrene. This is the management. And at some point, you can use bicarbonate also if there is acidosis to correct the acidosis. Okay, these are the various medications. Acute treatment, calcium gluconate, you have to give. How much the duration, how much I have to give, how much will be the duration, how it works is listed here. I will share the presentation. Insulin with and without glucose, within 15 minutes it occurs, this occurs immediately. And then how long I give? Around 2 hours. And then this shifts the potassium into the cell. And sometimes it may cause hypoglycemia, excess of insulin, you have to be aware of that. This is the third important treatment, beta agonist. Nebulize albuterol. Albuterol, within 30 minutes it works, and then shifts the potassium again into the cell. And subacute treatment, potassium binders. So acute, hyperacute treatment, calcium, immediate treatment, insulin, glucose or without glucose, albuterol nebulization, and slow treatment, subacute treatment, potassium binders. In chronic refractory cases, hemodialysis, peritoneal dialysis, renal replacement therapy will be required. So this is in a nutshell about the treatment of hyperkalemia and also evaluation. I think this is the last slide, and thank you very much.